So today we are going to see the Renin-Angiotensin-Aldosterone system. How does it contribute to the regulation of arterial pressure? So we know renin is basically a protease that is synthesized as an inactive precursor known as prorenin. Okay, so this prorenin is inactive and this is converted into active renin, which is synthesized. So this is secreted into circulation from the secretory cells. So what are the stimuli for secretion of renin? We will see first. So number one, it is decreased NaCl transport to the DCT or distal limb of distal portion of thick ascending limb. Distal portion of thick ascending limb of nephron. Second is decreased pressure or stretch within the renal afferent arteriole. This is second stimuli for renin secretion. And the third one is stimulation of sympathetic nervous system. Stimulation of sympathetic nervous system via beta adrenergic receptors. So these three are the stimuli. First is decreased NaCl to distal portion of thick ascending limb of loop of Henle. Then second is decreased pressure within the renal afferent arteriole, and third is stimulation of sympathetic nervous system via beta adrenergic receptors. Now once the renin is secreted, what does it do? So the function of renin is to convert angiotensinogen to angiotensin 1 first. So this occurs via renin. Now this angiotensin 1 is converted into angiotensin 2 with the help of an enzyme, angiotensin converting enzyme, which occurs within lungs in the pulmonary circulation. So this conversion happens in the pulmonary circulation. After angiotensin 2, this goes and binds with angiotensin 1 receptor, and this causes secretion of aldosterone. It also binds to angiotensin 2 receptor, and this angiotensin 2 receptor is something different. Wow! So this receptor, it has action opposite to angiotensin 1 receptor. Basically, this angiotensin 2 receptor, it improves vascular remodeling. So we can say it causes an improvement in the smooth muscle cell proliferation and regulation of GFR. And whenever we block angiotensin 1 receptor, it causes induction of angiotensin 2 receptor activity. So they act opposite to each other. Okay. Now once this aldosterone is released, we know aldosterone is secreted from adrenal glands, from the adrenal cortex. So this aldosterone is mineralocorticoid, is released from adrenal cortex, and one of the stimulation for aldosterone release is renin, while other is ACTH. Normally ACTH does not lead to regulation of aldosterone, but acute elevations in ACTH, if it is acutely elevated, acute elevations can lead to regulation of aldosterone in the way that it can increase aldosterone release. Okay, so after secretion of aldosterone, so we know it is a potent mineralocorticoid. What does it do? So it causes sodium reabsorption from the renal tubules and potassium excretion. So whenever sodium is reabsorbed, there will be increase in the blood pressure. So it causes increase in blood pressure as since the total volume increases, so there is volume expansion and hence there is increase in blood pressure. Also these mineralocorticoid receptors, they are present in other places, in heart, in kidneys and in blood vessels. So these mineralocorticoid actions over heart is, it causes myocardial fibrosis. So whenever these levels are increased for prolonged time, it will cause myocardial fibrosis and left ventricular hypertrophy. In kidneys, it will cause nephrosclerosis, and in blood vessels, it will cause inflammation. So vascular inflammation and hence remodeling. So overall cardiac remodeling that happens due to hypertension will occur because of this aldosterone. So these are the actions of aldosterone over different organs where its receptors are present, and hence when we use aldosterone antagonist, that is spironolactone, so this spironolactone impairs myocardial remodeling, so it inhibits myocardial fibrosis. So myocardial remodeling is inhibited and hence it has mortality benefit in heart failure patients. So this is a clinical aspect of RAS system.